If you're listening to this podcast on YouTube, for a better experience, switch to the video version. The link is in the top right corner of the video and in the episode description. Hello and welcome, I'm Fernando, a GP in the UK. Today we're reviewing the NICE guideline on hypertension in adults, always focusing on what is relevant in primary care only. In the last episode, we covered the diagnosis and initial assessment, and then we said that we would cover investigations for target organ damage and the criteria for urgent referral in this episode. So let's jump into it. For all people with hypertension, we should offer the following investigations for target organ damage. We should test for protein in the urine by sending a urine sample for albumin-creatinine ratio and test for hematuria using a reagent strip. We should take a blood sample to measure glycated hemoglobin, electrolytes, creatinine, eGFR, total cholesterol and HDL cholesterol. We should examine the fundi for hypertensive retinopathy, and we should arrange a 12-lead ECG. Examples of target organ damage include left ventricular hypertrophy, chronic kidney disease, hypertensive retinopathy, or an increased urine albumin-creatinine ratio. Now let's move on to identifying who to refer for same-day specialist review. We should consider this when a person has severe hypertension, defined as a clinic blood pressure of 180/120 or higher. However, referral depends on more than just the blood pressure reading. So, we should refer people for same-day specialist assessment if they have a clinic blood pressure of over 180/120 or higher, together with specific high-risk features. These include signs of retinal hemorrhage or papilledema, which indicate accelerated hypertension. Accelerated hypertension refers to a severe increase in blood pressure to 180/120 or higher, often above 220/120, with signs of retinal hemorrhage or papilledema. It is usually associated with new or progressive target organ damage, and it is also known as malignant hypertension. We should also refer for same-day assessment if there are life-threatening symptoms such as new onset confusion, chest pain, signs of heart failure, or acute kidney injury. We should also refer for same-day specialist assessment if pheochromocytoma is suspected. This may present with features such as labile or postural hypotension, headache, palpitations, pallor, abdominal pain, or sweating. So, as we can see, not all patients with a blood pressure of 180/120 or higher will need urgent specialist referral. So what do we do with patients who have severe hypertension, that is, who have a blood pressure of 180/120 or higher, but do not meet the urgent specialist referral criteria? Let's look at this group now. If a person has severe hypertension, but no symptoms or signs indicating same-day referral, we should carry out investigations for target organ damage as soon as possible. If target organ damage is identified, we should consider starting antihypertensive drug treatment immediately without waiting for the results of ambulatory blood pressure monitoring or home blood pressure monitoring. If no target organ damage is identified, we should confirm the diagnosis by either repeating the clinic blood pressure within 7 days or considering ambulatory blood pressure monitoring or home blood pressure monitoring if ambulatory monitoring is not suitable or not tolerated, and making sure that there is a clinical review within 7 days. Now, before we move on to the final definitions, let's summarize how to approach severe hypertension in practice. Severe hypertension is defined as a blood pressure of 180/120 or higher. At this level, the main question is whether there are symptoms or signs that indicate the need for urgent same-day specialist referral. Importantly, not all target organ damage means hypertensive emergency. NICE recommends urgent same-day referral only when severe hypertension is associated with specific high-risk features such as retinal hemorrhage or papilledema, or life-threatening symptoms like chest pain, confusion, heart failure, or acute kidney injury, or when pheochromocytoma is suspected. So, in practice, we're not simply looking for any target organ damage, but for features of acute, or ongoing organ damage that require immediate assessment. If these features are present, we call this hypertensive emergency, and we should refer the patient urgently for same-day specialist care. If they're not present, this is often referred to as hypertensive urgency as opposed to hypertensive emergency. Hypertensive urgency is more common, and the immediate risk of serious complications is generally low. In these cases, NICE advises that we should carry out investigations for target organ damage as soon as possible. But this doesn't necessarily mean hospital admission. Most patients can be managed safely in primary care with prompt investigations, close follow-up, and appropriate initiation or adjustments of treatment. We need to remember that in the absence of acute organ damage, blood pressure should be reduced gradually rather than quickly to avoid complications such as cerebral or renal hypoperfusion. So overall, the main message is to identify red flag features that require urgent referral and to use our clinical judgment. Now, before ending this episode, let's quickly clarify some definitions used in the guideline. Stage 1 hypertension is defined as clinic blood pressure between 140/90 and 159/99, with corresponding ambulatory or home averages between 135/85 and 149/94. Stage 2 hypertension is defined as clinic blood pressure of 160/100 or higher, but below 180/120. With ambulatory or home averages of 150/95 or higher. Stage 3 or severe hypertension is defined as clinic systolic blood pressure of 180 or higher, or diastolic blood pressure of 120 or higher. White coat effect is when the clinic blood pressure is higher by more than 20/10 millimeters of mercury, compared with readings taken outside the clinic. Finally, at the opposite end of the spectrum, masked hypertension occurs when clinic blood pressure is normal, that is below 140/90, but is higher outside the clinic on ambulatory or home monitoring. So that is it, a review of the section of the NICE guideline on hypertension. We have come to the end of this episode. Remember that this is not medical advice, but only my summary and my interpretation of the guidelines. You must always use your clinical judgment. Thank you for listening, and goodbye.